Good afternoon, everyone. Good afternoon, Laura. Good afternoon, Dr. George. And we have a big crowd there at TTOHC Internal Medicine. This is also part of the Internal Medicine Grand Round. So welcome, everyone. My name is Ariel Santos. I'm the Director of Telemedicine and Chief of Acute Care Surgery here at TTOHC, and also an active member of SCCM Surgery Section. I would like to thank Dr. Shermer, for including this as a collaborative project as part of the Grand Rounds for TTOHC Internal Medicine Grand Rounds. And I would like to thank my co-host, Dr. George, as well as Dr. Nicole Siparsky, who will be moderating this session. Of course, our presenter, Dr. Natalia Aris-Mendez. I would like to thank as well the Office of the Dean, Dr. Burke, the DAIO office, as well as the chair of the surgery section, Dr. Ahmad, for collaborating this. This is a joint project of TexLa TRC, as well as the SCCM surgery section. Dr. George?
A quick acknowledgement. This educational activity is a project of the TexLa Telehealth Resource Center, a federally funded program with F. Murray Hall Rural and Community Health at TTOHC, as well as Well Ahead Louisiana, with generous support from Health Resources and Services Administration. This is a collaboration with the Society of Critical Care Medicine Surgery Section. And thanks to Dr. Shermer for being part of this whole event.
All right, next slide, Laura. This is just a small tips, Dr.
Yes.
George.
Yes, and also here are some helpful tips for you. Also, kindly type in your name and email address in the chat box, and if you have any questions or comments.
All right, so to introduce our speaker and panelist is our moderator, the Chief of Acute Care Surgery and Surgical Critical Care at Rush University Medical Center in Chicago, my colleague and my friend at SCCM Surgery Section, Associate Professor Dr. Nicole Siparsky.
Thank you very much for the warm welcome, and hello to the Zoom sphere, colleagues and friends. It is my pleasure to moderate this hour. I have the distinct pleasure of introducing our speaker, and later I will introduce our panelists, and we will provide a lively discussion to stimulate your mind and get you thinking about very challenging ideas and topics. To start this off, I'd like to introduce Dr. Aris-Mendez. She is a physician of internal medicine, and she is currently the critical care fellow, one of the critical care fellows at the University of Pittsburgh Medical Center. She also is the Equity and Inclusion Officer for her fellowship. She will be speaking today on the topic of diversity, equity, and inclusion. Take it away.
All right.
Where is it?
Probably close the slide first. We'll just have a slight technical difficulties. We'll be right with you in a minute.
That's a screen one. It's a screen one, right? And I think to close that. Share the screen one, hit the screen share, and then you close this.
Close this?
Uh-huh.
Exit.
Okay. down at the base.
I don't hear the sound playing.
I'm sorry, I'm not hearing any sound.
Can we pause?
Let me share the voice.
Are you guys hearing the audio by any chance?
No, we're not.
Okay. So I think we share, you have to share, when you share the screen, you have to share the voice too.
Share the screen. All right. On top. Share.
Share. Sharing options. Stop the share, and then reshare again.
So stop screen and it run.
Yes, and then down, there's a share sound. There's a share sound. You know, you go back to that screen.
Share screen.
Yeah, see the share sound. Sorry. Okay. So let's back it up. Yeah.
Probably, yeah, probably a little bit forward. No, share or
Yeah, I have the wrong screen.
forward it a little bit more. Okay.
To elucidate how inequity, bias, and racism
Pause.
negatively impact.
Can you hear it now?
Yes.
Play.
Yes, we can hear that. So I think we just need
and
to start
propose
over.
solutions to address current problems and barriers. So it's helpful to start with a review of many different factors that influence the outcomes, the health outcomes of our patients. So there's an overwhelming amount of data on numerous elements that contribute to the health of our patients. This is not an all-inclusive list, but you can see a variety of systems that disenfranchise certain populations, commonly being Black and Brown communities. When we review studies on public health and healthcare disparities, there are racist structural policies and regulations that affect our patients' health. Now, broadly speaking, these are in the forms of government, medical, educational, and economic systems. What we find is that Black and Brown patients have more economic and financial challenges, increased occupational hazards, increased poverty rates, environmental hazards such as water and air pollution, language barriers with less social support, more violent encounters in relation to exposures to law enforcement, parenting, neighborhood communities, and increased sexual, physical, and emotional abuse. All of this leading to high levels of stress with minimal social support, therefore leading to an increased risk of adopting unhealthy coping mechanisms and leading to worse physiologic outcomes, such as depression, cancers, cardiovascular disease, polysubstance abuse, and death. A lot of these can stem or originate from experiences in childhood. This particular publication focused on childhood adverse events, and this was defined as forms of physical, emotional, and sexual abuse, household mental illness, household substance abuse, domestic violence, household members who were incarcerated, parental separation or divorce. And what they found that although these were common across all socio-demographic characteristics, this particular study identified certain at-risk groups being multiracial, Black and Latino, as well as lesbian, gay, and bisexual community. They also found increased risk of childhood adverse events in individuals of low income and less educational attainment. And now not included in a lot of our studies are our disadvantaged Indigenous populations. And what you see here is that overall they have a high all-cause mortality and higher rates of comorbidities such as diabetes, alcohol abuse, and liver disease. In particular, the Lakota tribe, which is located on Pine Ridge Reservation in South Dakota, has the lowest life expectancy. And plotted on here is data collected from the Pine Ridge Hospital as well as the World Health Organization. And you see that the life expectancy, average life expectancy for the male ranges between 46 to 48 years old, and for females, 54 to 56 years old. And the United States is circled here in blue, where the average life expectancy for men is 81 years old, and for women, 79. And again, extreme rates of poverty with the Lakota tribe and Pine Ridge. So what do we do with all of our money, our healthcare dollars, and where do we spend most of our money, and how does that relate to race? Well, this was a recently published article, and healthcare spending by race and ethnicity was evaluated from 2002 through 2016. And healthcare spending per person was analyzed in relation to healthcare utilization, price, and intensity. And in total, after reviewing 7.3 million visits in the United States, almost totaling to $30 trillion across 6 different types of healthcare. Now, these types of healthcare were defined as ambulatory, emergency, inpatient, nursing facility care, prescribed pharmaceuticals, and dental care. What I have highlighted here is you can see that the disparity in healthcare dollar spending has persisted from 2002 through 2016, where the vast majority of money is spent on white individuals. Now, when we look at 2016, the United States spent 72% on white individuals who made up 61% of the total population at the time. The largest discrepancy was seen in the Latino group, in which they represented 18% of the total population, and only 11% of total United States spending dollars was spent on this group. For the Black community, they made up 12% of the total population in 2016, and 11% of healthcare dollars was spent on this subgroup. Now, utilization of spending differed by healthcare type. Now, what we see here is age standardized distribution of spending by race. Now, the main drivers of observed changes over time was evaluated by a decomposition analysis. So each bar represents the relative difference in spending for each group relative to all population spending for each of the types of care. So the blue arrow is relative differences attributed to utilization, while the orange one refers to the differences in price and intensity of treatment. And at the top left, in the Native groups, I have circled here that the majority of healthcare dollars was spent on emergency departments. And this was estimated to be about 90% compared to any other population. Just below that, in Group C, an Asian, Native Hawaiian, as well as Pacific Islander, the least amount of spending on all types was observed except for dental care. Below that, under E, for Black individuals, about 19% more was spent on inpatient and more was spent on emergency care compared to other groups. In the top right, we have the Latino subgroup, and you can see that a significantly less amount of spending per person for ambulatory care, for dental, nursing facility, as well as prescribed pharmaceuticals. And D, under a multi-racial group, more estimated spending was seen except for nursing care. And on the bottom right are white individuals estimated a higher spending on ambulatory care, dental, prescribed pharmaceuticals, and this likely contributed to higher utilization. So now, is it a problem with access to care? Because that would be our next question. Well, when we review our trends, this publication was a survey, and they surveyed almost 600,000 people, and highlighted on this slide are Latinos reporting higher rates of uninsurance status. And then in the Latino community, as well as with the Asian community, not seeing a physician or a healthcare professional in the past 12 months, as well as the Latinos and Black community delaying cost or delaying healthcare due to concerns for cost. So there are several different components that increase their comorbidities for our patients, affect their life expectancies, as well as making it challenging to even access healthcare. So what happens when we see these patients in our ICUs? Well, this was a recently published article by Dr. Cantor last year. And what they looked at were income disparities and access to critical care resources. So data was collected from Centers for Medicare and Medicaid Services, and ICU beds were determined by each hospital service area. Demographics were collected, and then all of this information was aggregated by zip code into hospital serving areas where residents receive most of their hospital care. So in total, they had 4,518 hospitals in 50 states, and this came out to 3,160 HSAs or hospital service areas. And these are their results. So half of the HSAs with the lowest median household incomes had 0 ICU beds, compared with just 3% of HSAs with household incomes of at least 90,000. And you see that this disparity is further amplified in the rural communities, where even at the lowest median household income, over 50%, almost 55% of HSAs had 0 ICU beds. And in the urban communities at the same lowest median household income, just over 30% having 0 ICU beds. Now, ICU bed access across the country is depicted on this slide, where the lighter turquoise represents 0 ICU beds per 10,000 residents aged 50 and above, and as the colors darkened, increased beds per resident. So now what happens with our outcomes? So we have limited ICU beds and resources. What is it that we're seeing as far as our critical care outcomes? This recent study excuse me, this study in particular looked at critical care outcomes in hospitals across the country. And they defined hospitals serving primarily Black and Latino patients if they treated more than 25% of non-white individuals. And these were their results. Now you can see that over the last 10 years, although the risk of critical illness mortality has decreased, outcomes within hospitals treating primarily Black and Latino patients did not improve comparably. And this was statistically significant. Excuse me. The temporal inequality was most apparent among Black patients, and about each calendar year was associated with 3% lower adjusted mortality in primarily white serving hospitals, but there was no change in hospitals that served people of color. And looking at the length of stay in the hospital as well as the ICU, they were longer in primarily Black and Latino serving hospitals. And with everything that we have reviewed so far, we must be conscientious of how we as providers impact patient care. That brings us into our next topic, which is bias, and I will focus primarily on implicit bias. Now, implicit bias is the automatic or involuntary attitudes that we have about members of distinct social groups. Now, they don't necessarily align with our outstated beliefs, but tend to favor our own in-group. So why is this important? Well, this is important because our biases affect how we perceive and then how we treat our patients. Now, there are so many studies out there, and this one here is a systematic review and highlights not only race-based biases, but biases in the form of age, patients with AIDS or back injuries, differently abled individuals, gender-based, and all of these factors with bias influences how we diagnose, manage, and prognosticate. So it's not surprising that our marginalized communities would be impacted most when there's a virus with such severe complications like ARDS and death, such as in the pandemic. And I think we all can attest to that. And this meta-analysis that was put out by Mangeesh and colleagues reported the COVID-19 outcomes in the United States. And they looked at from the time frame from January 2020 to January 2021, and found that in the groups of Black, Latino, and Asian individuals, they were most likely to test positive, have the highest prevalence, the highest ICU admission rates, and the highest disease severity. And Latinos testing positive for COVID, there was an association with lack of access to primary care providers. And in the COVID positive Black individuals, there was an association with an uninsured status. looking at the area deprivation index, which is a tool used to measure socioeconomic status, there was a higher mortality noted in Latino and Asian communities. And after adjusting for socioeconomic and social determinants of health, there was a decrease in COVID positivity. However, there were some inconsistencies in the total mortality between different ethnic subgroups based off of the design, the study design, whether it was a cohort versus cross-sectional study. And this also goes for relating mortality to the median income. So if the pandemic ever ends, we can hopefully look at this and update the slides. Now, I'd like to draw your attention to this study. And the reason for that is because they wanted to run a simulation and see if everything that we have mentioned before about Black and Brown patients having a higher mortality in hospitals, what would happen if they were admitted to a hospital that primarily treats white patients. So first, what they did was a cohort between January 2020 through September 2020, and they looked at the 30-day inpatient mortality. Excuse me. And then they conducted a simulation to estimate the mortality among Black patients admitted to where white patients were more likely to present. And on this distribution here at the bottom, you can see that if Black patients were admitted to primarily white serving hospitals, there was less mortality. So what can we do? What should our next steps be in creating solutions to mitigate these outcomes? Now, they can be grouped in several different ways. I have my potential solutions starting with diversity in education, but there's an overwhelming amount of opportunities. And I think it's important to create an inclusive, a diverse environment in the forms of leadership and medical training, and then increasing our awareness through education. Now, you could strategize with your DE&I committees, as well as get expert recommendations, because there are experts in this field who are available and eager for consultation. I've also listed a few of my favorite books here. For again, increasing awareness, but also getting different approaches to, you know, how do you bring about change within your community. And this is not necessarily in the healthcare field. It can be in many different environments. Now, looking into the research department, engaging in and supporting community engaged research and supporting implementation science training. We should also try to diversify our editorial board and publish Black and Brown research, and then connect the academic and the community hospitals. And I really want to emphasize this because the community outreach is so important. And as I've mentioned previously, the inequities that we see in not only ICU resources and mortality differences, but creating more of a partnership between rural and urban communities to not only expand our resources, but get a better understanding of the barriers and the challenges that they face. And then, of course, there's always advocating for change within the government, the local government that we can undertake. So this is a summary of interventions at multiple levels, some of which I previously mentioned, but I would like to wrap up here so we can get on with some questions. Thank you again. Just remember, the change starts with you and it starts now. I have my contact information here. I'm more than happy to, you know, brainstorm some potential solutions, share information. I think that is the most important thing, is creating a network. And so please contact me. Thank you.
Thanks for that talk very much. We're in a room here in Lubbock, Texas, and we'll see if we have any questions on the floor.
Thank you. Sorry, I have some upper respiratory symptoms, so I apologize.
Are we unmuted? Thank you very much, Dr. Aris Mendez. And sorry earlier for the technical difficulties, but we would like to thank Dr. Shermer again. Dr. Shermer, any words before we start with the discussion?
No, I think we'll do the legwork on the back end to make this count as a DEI hour. We'll it certainly would qualify, and we'll make sure we have the documentation necessary to be credited to everyone.
Excellent.
Very useful training. Thanks.
Yes, sir. Then I will pass the baton now to my associate here, Dr. Nicole Siparsky of Rush University.
Thank you, Dr. Santos. It's my pleasure to be the moderator of this panel discussion today. I would like to welcome two of my esteemed colleagues, Dr. Tia Price and Dr. Elliot Jesse. Dr. Price is my colleague here at Rush University Medical Center. She is an assistant professor of surgery. She is our wound care director. She is a surgeon intensivist. And to be totally honest, she's just an amazing person all around. So welcome, Dr. Price. I'd also like to welcome Dr. Elliot Jesse. Dr. Jesse is the Chief of Acute Care Surgery and Surgical Critical Care in the Navy. He is Associate Program Director for General Surgery at Walter Reed, and he is co-director of the Surgical Intensive Care Unit. He's also an Assistant Professor of Surgery. Welcome, Dr. Jesse. We go way back to residency, so hopefully he will not share any embarrassing anecdotes about me during this talk.
You didn't pay me this time, so all bets are off.
So what I'd like to do is offer up some very interesting ideas and questions. Some of these ideas are designed to provoke your thought process internally and also to get conversations started on difficult topics. And there are other things for which there's no single solution or right answer. And so I'd like to start with Dr. Price. Dr. Price, a lot of people feel that traditional gender roles are a thing of the past. Now women and men do everything and it's a thing of the past. But there are others who feel that traditional gender roles continue to hold both men and women back in the medical workplace. And so my question for you is, how do you feel we could better achieve equity and inclusion for both men and women in our workplace?
I mean, I think you have to be very deliberate about it. So I unfortunately have a colleague who actually left her place of employment because she constantly asked for help with research projects and academic promotion. And yet when she looked around, she found that all of the research products that were, or the research projects that were already in motion or were very easy to start were preferentially given to her white male colleagues. And so I think it's something that you have to be just incredibly deliberate about, right? So you have to look at it, you have to determine, are you actually choosing just based purely upon the best person for the job, and are you making sure that opportunities are equitable across the board? So I don't think it's something that you can just assume is happening, nor is it something that you can hope is happening. It's something that you actually have to keep records of and check on a regular basis. And that's probably the first thing. And then I think education as well. I mean, unfortunately, traditional gender roles, it does not just, so in the operating room, for example, I think sometimes we find, and I bet everybody has a story to this part, that sometimes actually the female operative room nurses are actually some of the more, I don't know how to put it, obvious when it comes to preferring men over women. So for example, women getting written up for jewelry, wearing in the operating room when men also wear jewelry and have never been written up. Male colleagues getting second rooms when that never really happens to me, I'll tell you that much. Just getting offered second rooms from OR charge nurses without having to be asked. You know, I think all of those are, so I think, education all the time. And again, tracking these things and reviewing them and then working on them from a systemic standpoint and from an administrative standpoint.
Thank you. Dr. Jesse, how would you go about improving the equity and inclusion of both men and women in the workplace?
You know, I would like to echo those sentiments. I think, you know, a lot of it has to do with, you know, our own, you know, unrecognized implicit biases. And I think, you know, that non-recognition causes us to outwardly, you know, affect other people. So I think, you know, education, things like this, you know, more discussion that it actually, you know, sort of exists, I think goes a long way in improving that.
And it sounds like from both of you, I'm hearing sort of, but not really solidly stated, would be some element of direct accountability at a leadership level, having leaders that are going out of their way to ensure that this is the case and ensure that these issues are addressed when they're brought to their attention aggressively, because a lot of things are sort of mentioned in passing and joked around about or laughed at, and there's no real accountability at a higher level. So having leaders that really promote this culture, or at least try to encourage a shift in culture towards that is also important.
I think you have to encourage everybody to speak as well, because, you know, you have residents who get physically threatened, you know, feel physically intimidated, and they don't say anything because they don't feel like it will be heard. So I think we also have to do that. And I will say too, just to, before we move on, I think some of this is self-perpetuated as well. So, you know, for example, I was operating with one of my male colleagues, and I found that I fell into almost the chief surgical role without even thinking about it. Right. So I started moving my headlamp so that he could see what he was doing, and started taking instructions from him. And then like halfway through the procedure, I'm like, what am I doing? And so I think we have to recognize it too, that we are raised with those biases. And sometimes, and this is why education is so necessary, sometimes we don't even know that the behavior that we're exhibiting is a result of those biases that we have been raised with traditionally. And so, you know, education.
That's actually very true. And there's a really interesting book that was authored many years ago by a sociologist that was embedded in a surgery residency for many months. And she became so embedded into the workplace that people stopped noticing that she was there. And what she observed while she was there, she ultimately went on to include in her book. And one of the things she described was that female trainees are often treated in one of two ways by male mentors. Either female trainee falls into a daughter role, and the male mentor will fatherly guide her through her training and protect her from problems, help her overcome challenges, and really develop a fatherly-like mentor-mentee relationship, or they would be largely ignored. And that is an example of traditional gender roles, both by mentors and mentees, that it's a two-way process for both men and women. And that's old data now, but I still think it's very much true today. So it, I think, takes constant personal and workplace vigilance to really keep on top of some of these occurrences.
Dr. Saparsky, I'd just like to add as well that, you know, whenever we observe something like this, you know, the inequity, that's what's going on, we should probably speak up. We cannot just, you know, keep quiet. I observed several times, and this is when I was in the ICU last week, you know, a doctor, anesthesiologist doctor need to wear MD behind, you know, make sure doctor, physician in their ID. I don't have that in my ID, but the woman physician had to, you know, because they're always been asked, are you the nurse? Even though there's already MD in that. Happens as well, you know, intensivist, wherein she's not wearing her white coat. You know, does she need to wear her white coat to say that she could be a female doctor? So that she could be a physician, I think we had to speak out on those, and we had to support our colleagues whenever those things happen.
That is a very good point. Thank you. And before I forget, I also had one more note for the audience before we move on. We actually have the very kind addition of sources in our chat stream that are provided by our illustrious librarian, Dan Stewart from Texas Tech. So thank you, Dan, for putting those references in for us. If you're looking for some information about the data that you've heard about today, you may find the reference in the chat box. If not, I'm sure Dr. Santos could provide it for you if you send him an email. Okay, so moving on, I have now a scenario that I'd like to share with you. This was a scenario that was shared with me and is very interesting and I think thought-provoking. And so I'd like to share it with you all and to get your thoughts. So at this moment in time, I think that diversity, equity, and inclusion represent concepts that are very much in the forefront of education. I have never heard talks on this topic in the 20 years I've been in surgery until this year, and I've heard a number of talks this year on this topic. So I do think that there is an active effort at a national level to improve everything in this way. But there is an interesting process that has gotten underway that I'd like to share with you. So to this point, so there is a concept called reverse racism that has been getting attention in the media. Conceptually, for those of you who are not familiar with it, it is the belief that either social, economic, or political professional gains can occur as a result of minority peoples experiencing improvements in the quality of their day-to-day. In other words, by improving disparities, whites will be unfairly disadvantaged. Now, this is a very controversial topic, which is why I bring it up. I actually only recently learned about it, and I'd be interested to hear what the panel has to say on the topic of reverse racism. And I think this time I'll start with Dr. Jesse.
Sure. You know, I have many thoughts on, you know, reverse racism. First, I think conceptually, it is not a sound concept because it's essentially based on the fact that if I give more to you, then I will naturally have less. And, you know, it's very difficult, you know, for, you know, minorities to sort of hear the concept of reverse racism, which is largely historically, you know, we have been perpetuated on by the majority, right? You go back in any past, you know, civil rights, what have you. So it's, you know, I sort of striking reverse racism in the same line as when, you know, I may call up my colleagues and say, hey, you know, what you did right there is a little, you know, kind of racist, or that can be implied that there's some racism going on. And then the colleagues respond, well, you know, it's not like that. That's, you know, how could you take it like that? I'm like, well, you don't get to determine, you know, what the perpetuator of racism doesn't get to determine what racism is. It doesn't work that way. And so similar with the concept of reverse racism, you know, minorities, you know, have traditionally with, you know, multiple, you know, things that are kind of baked into our society have been disadvantaged. And so, you know, most of, you know, a lot of people have recognized those historical disadvantages and have, you know, not have sought to reverse those. And so I don't see that as reverse racism. I see that as, you know, not righting the ship, to use a Navy term, but kind of righting the ship, in that giving opportunities that didn't exist or people didn't have access to prior, be that, you know, because of race, socioeconomic status, gender, so on and so forth. It's about giving people the opportunity to do better. And just because those people now have those opportunities and they may be qualified to participate in those opportunities doesn't mean that, you know, they're taking it from you, right? If we live in a meritocracy and people are supposed to get what they get because they earned it, giving somebody the opportunity to earn it is not a bad thing, right? That's what it's supposed to be. That's quality.
That is an interesting perspective, and I really appreciate you explaining that view. Conceptually, the argument it sounds like you are in favor of is that opportunity is not a scarce resource. It is something that is available, should be available to everybody, and that fairness is not something that is limited. It is a limitless thing that everybody should be able to experience. By allowing opportunities for everyone, you ensure fairness for everyone, and nobody should be disadvantaged in that way, if I am understanding correctly.
Correct.
Dr. Price, do you have any thoughts on this?
Yeah, so I think about this a lot, and honestly, the best way that I have learned to describe it to people is the phrase zero-sum game. So a zero-sum game is any game in which for one person to win, another has to lose. So football, tennis, Monopoly, whatever. If you get a point, another person does not get a point. That is a zero-sum game. Life is not a zero-sum game. One person does not have to lose for another person to win. One person does not have to fail for another person to succeed. And that is the way that I have found it to make most sense to the people that I am describing this concept to. And another phrase that I use is just that in the past, minorities, patients of lower socioeconomic status, sexual identity, however, whatever, minoritized groups, we just want to start at the same starting line. That's it. We're not asking to have a 10-second head start. We're not asking to have a shorter distance to run. We're asking to start at the same starting line that Caucasian people have been able to start at since the beginning of time. That is all. That's it. Where we get from that starting line is completely dependent upon us, but we just want to start at the same place.
It's a very challenging concept, I think, for some people to really grasp, because in many of our experiences, for those of us who, well, most of us who are on this Zoom, I would say that most of us worked very hard to get to where we are. We competed with a lot of other people to go to college, to go to medical school, or to do advanced training, for example, in our specialty. For those of us who had to compete for a small number of spots or resources, I think we are intuitively in competitive mode every day. Some of it's a competition with ourselves, always trying to bring our very best self to the care of our patients. And so I think erroneously, many people feel like it should be a competition, and that it becomes a competition between races or sexes, or within a group of for a specialty, when in fact it really should be just a fair environment for all to push themselves in to excel. Thank you very much for your thoughts on that.
Can I just mention something too,
Yeah.
just to piggyback off of what Dr. Jesse and Dr. Price mentioned, because, you know, we shared a lot of information today about historically marginalized groups, which are typically Black and Brown communities, but we shouldn't forget that also in lower socioeconomic areas, there are white individuals. And so it's not like you mentioned one race versus the other, one group of populations. By redistributing our resources and the way that we provide care and giving more equitable care will improve outcomes for white individuals as well.
Which is an interesting thought, and people forget that is also a potential benefit, that everybody will win from it. Thank you very much. I have my next question. I have a scenario that recently was described to me by a colleague, and I thought was very thought-provoking, and I'd like to share it with you. So in this scenario, a non-English speaking family had a family member admitted to the ICU, and that family member was critically ill. In that patient's family culture, everybody comes to the hospital when one person is sick, and they all stay close by the patient. At many times during this day, they provide translation for providers, nurses, doctors, and other people interacting with the patient at the bedside, because the patient doesn't speak English and is elderly. So in this scenario, the ICU nurse, following ICU policy, restricted the family to 2 visitors at a time. And they got very upset. They accused the nurse of being racist and insensitive to the family culture, when in fact the nurse was just enforcing the ICU visitor restriction policy. Also, in a similar scenario, family members at the bedside trying to translate for the patient were actively promoting poor care and miscommunication through incomplete translation by insisting that they provide the translational services that the providers needed, rather than an official interpreter who is certified. So my question for you is, how would you handle this scenario, and what do you think we can do as a society to improve the care of patients who are non-English speaking, because these scenarios are becoming more common. I encounter this with some regularity now, whereas I didn't as much before. And I think I'll start with Dr. Santos.
Well, I think whenever that happens, we should maintain our equanimity. I think being too emotional, or equalizing, or whenever a reaction, there's always some opposite reaction. I think we should be mindful and professional about this, and probably we could ask the help of those patients belong, or one of our colleagues who have the same ethnicity, or familiar with the culture, to help us explain what we want to happen, that we're just enforcing the rules and regulations of the hospital. But I think we had to be less. It's easy to say than done. Not to be too sensitive about this. This is our growing issues. We have to evolve about this. There's some growing pain on it. Our feelings may be hurt, but sometimes we had to put ourselves in the shoe of the patient. They're suffering, and so this is what I sometimes mention to my colleagues in the ICU. Whenever they encounter things like this, and I agree with you, it's becoming more common.
Dr. Jesse's actually been deployed on numerous missions in the military, and I'd be curious to hear your perspective on this, because you've been faced with not only this issue in stateside, but I imagine abroad, taking care of locals in where you're working.
Yes, even more recently, with the recent events in Afghanistan, we took care of a fair number of Afghan patients at Walter Reed, and it was very difficult from a communication standpoint, because there was a sort of a language barrier and a cultural barrier. Now, I can tell you, the military is very good that, prior to my deployments, they actually taught us, or at least attempted to teach us a little bit of the language. But we did have a lot of classes based on culture and, what is, acceptable per the Afghan culture, because sometimes what is acceptable for us, or our expectations, are not the cultural norms for someone else. And you can't project what we would expect, or what is our right and wrong, onto that culture, because that is not, I don't believe that's our job. Our job is to function within the culture in which we're treating. And so, at times, I can name several scenarios where, one in particular, where I was deployed, we took care of this, infant child, and it the child didn't make it, and I had to tell her, brother, his sister, just passed away. And, from, Western medicine, that's a devastating event. I was, child and upset, and I'm figuring out how I'm going to relay the message. And I related to her brother, and, I found him consoling me, because to him, sure, his sister, just passed, but, it happens, and, move on. And I turned to the translator. I was like, I don't understand, you know, how he could be so, nonchalant about it, and found myself sort of getting upset. And the translator relayed that, this is a cultural thing, right? Like, you don't show emotions, and your sister just passed. Okay, move on. Life keeps moving. And so, that's sort of one of my personal examples. But I think it's, it's key for us to, not make assumptions, not, again, put our own biases in it, and sort of work within the people who we're taking care of.
To be perhaps more flexible than we're even comfortable being in our typical day-to-day activity. Thank you. I appreciate you sharing that.
It's important to recognize that people, that sometimes, like when somebody says, oh, I don't want to use an interpreter, or, oh, I don't want my family member to know about their diagnosis, or things like that, we think about it in our Western culture. But the reality is that in many, many cultures, all decisions are made by community. It's not uncommon to hide dire diagnosis from your elderly relatives that's considered respectful and loving towards them. And not wanting to use interpreters can often be, number one, an incredible source of pride for the family, that they don't have to use an interpreter because they've tried so hard to assimilate into our culture. And when somebody reminds them that it's not good enough, that can be very difficult. And the other thing too is that many cultures are also very private, and they would prefer to have interpretation between their doctor from a family member than a third party that they don't feel comfortable with, even if that person is a licensed medical interpreter. So I agree with my colleagues in that I think that you have to look at each case individually. Now, if you feel that you're in an area where you would be potentially harming the patient or their care by not using an interpreter, then I think you just have to explain that and say, listen, I recognize that you're incredibly fluent, but much of this language is, you have to have had some medical education to understand those terms in your native language. And so, while I respect and appreciate your fluency, it would really help in the care of this patient if you would consider using an interpreter. And I think that that's the way to try to put it.
I actually had a very interesting scenario once when I was taking care of an ICU patient, where the bedside family spoke a language I didn't speak, that was not English. And they had their holy man come from their local religious institution to be with them. And the holy man actually told me that the family wasn't interpreting what I was saying accurately. And it was, they had previously refused the interpreter. And it was really interesting that he pointed that out, because we were able to make some real progress in goals of care decision-making once we identified that issue. And I insisted that they have an interpreter for legal reasons, because I did not feel that they were completely understanding what I was saying, and they were expected to make decisions on the family, on the patient's behalf. So it was an interesting spin I wasn't expecting. Thank you very much. I really appreciate all of those comments. Before we close at our hour, I have the $1 million question. And the $1 million question is basically, if you could have at your disposal $1 million, which used to be a lot more than before than it is now, but if you had $1 million, what would you do to dramatically and immediately improve diversity, equity, and inclusion in your personal workplace? And I'd like to start with thanking Dr. Arizmendez for her fantastic presentation and give her the first chance to answer this question.
Thank you. Well, if I had $1 million, I would probably expand our resources in telemedicine, especially, sharing the results and the inequities. I see Laura over there, sharing the inequities that we see even in the urban facilities, as well as in the rural communities. And I think that in itself would pay for itself, right? Because you would have consultants, you could do this with critical care medicine, and you could really improve the patient outcomes in those communities. So that would be my number one, my number one that I would take.
So when you open up your startup telemedicine company and we all get some penny stock in it, we'll eventually be highly successful and we'll be retiring to our personal island. It's a great idea. Thank you again for your wonderful talk. Dr.
Yes.
Sanchez, what would you do with your $1 million?
For my $1 million, I will invest it in education and research. I think we need a lot of research moving forward. I'd just like to plug, the paper we wrote, call on a categorization of sex, gender, race, and ethnicity in surgical research, because most of the research right now are so binary, male, female. We're leaving out a lot of people, and the race is white, and African-American and others. I think we had to be more granular in some of our research. Dr. George?
Yes. Thank you for the great panel discussion. We had a great time and we have a valuable insight into this burning topic. Today, kindly please fill your session evaluations to receive the CME credits. We will also email the link. And we will also present Doctors Aris Mendez, Siparsky, Price, Jesse, and Lee, the Texas Tech and TexLa Challenge coin that we'll be mailing it to you as a sign of appreciation for your participation and commitment in the field of diversity and equity and inclusion. Thank you all.
Thank you.
Okay, could I ask Dr. Price, and Dr. Williams, they haven't answered the $1 million question yet.
No, I agree with you, Dr. Santos. Like, for example, I just put on the chat, because I think one thing that I think we could change in our language very quickly. So I agree about research and understanding, because something we could change in our language really quickly is I was always taught, oh, the usual symptoms of this disease are X, Y, and Z, and then women or fill in the blank have atypical symptoms like this. And I think honestly, the answer is no. We've only studied symptoms for the most part in Caucasian males. So do women actually have atypical symptoms, or do they have completely typical symptoms for women? And that's where I think we have to change our language, right? We have to stop teaching people that things are typical and atypical, because we've really only studied them in one population. And so I agree, we need to go back and do research so we understand how does actually every population group respond to these disease processes, and how do we teach our trainees to recognize those appropriately.
That is a very good point. An example of that is the study of nutrition, which is, I think, fair to say, affects pretty much every hospital patient around the world. Nutrition is a huge topic, and almost all nutritional studies, the foundational studies, were performed in healthy young white men who happen to weigh exactly 70 kilograms. So it is very true across many specialties. So that work is desperately needed. And if I had $100 million, I would give it to you to do it. Unless Dr. Jesse had a better idea. Dr. Jesse? I think he's laughing and muting it.
He's
No,
scared.
I think, if I had
Dr. Price can
$100 million
answer.
or, 50 cents. Can you guys hear me?
Yes.
Uh-oh. Can you guys hear me? So I think, if I had the money to tackle some of the healthcare disparities, I would sort of target businesses that hire some of the people along the lower social economic spectrum, and pay for them to have 2 paid days off from work to actually go see a primary care physician to get the actual health care. Because of a lot of people, and people in my family, don't see a doctor because they can't afford to go see a doctor because they can't afford to take a day off to go make a primary care appointment. And, if when they can, it's usually after the hours of primary care appointments, which is why they turn up in the emergency department, with all of these sort of health issues that can be maintained, but not maintained. And so they use that as a primary.
That's a really good idea, going back to the basics of where good health starts and how you promote it. And I love that idea. We actually have started doing that with our residents here at Rush. Our general surgery residents now get time off. I forget exactly how much, but they get a half a day or a whole day with some regularity.
I advocated for this. So they get a half day off per at least once in their rotation, so they can go get their teeth cleaned, go to the DMV, things like that. So yeah, they get at least one half day off per rotation, but I think most try to do better.
Yeah, we have a zero disciplinary policy here at Rush, in addition to our strong feelings on diversity and equity and inclusion. So no, all jokes
Siparsky, our resident, doesn't work more than 12 hours.
I wish I could say that for ours. Ours work very hard. But I will say that's very true, not only for our patients who have very little or no resources, but for ourselves too. I think it's just as true for the executives and the hardworking white collar professionals and educated people who don't take care of themselves because they work too hard. I once saw a really insightful quote. It said, "You can take the time to take care of yourself now, or you'll make the time when you get sick later." It was something like that. And it was very insightful. A closing thought, I will share with you what I would do with my $1 million. In full disclosure, I'm not a multimillionaire, but I would say, and I think this is true for Dr. Price as well, that if I was a multimillionaire, I actually would not retire to an island. I would probably come to work and do the exact same thing that I do every day. But if I had that extra 100 million, I would probably do something in Hollywood to change how all medical providers are portrayed in TV and television, in movies, commercials, to make it a more equitable portrayal of healthcare providers in all specialties and environments. Because there are some stereotypes that are promoted in magazine advertisements and on TV and in the movies. And I think some of it starts with just how we are displayed, how we are perceived by the community. And that starts with how they see us in modern common ways. So before I close, I'd like to welcome the audience to ask any questions or make any comments that they have. I will thank the audience for adding to the chat box throughout the hour with some very interesting thoughts and ideas, and open the airwaves to you now.
Any question there, Dr. Shermer, at the any question, Dr. George?
No, I think I'm good.
All right. I guess there's no more question, Dr. Siparsky. Could we move this slide, Laura?
The software is done.
Okay. Well, thank you, Dr. Siparsky, for moderating this. Thank you very much, Dr. Arismendes. I know you're sick, but thank you for, showing up here with us. Thank you, Dr. Williams, Jesse, Dr. Thea Price. Thank you so much. Nice to meet you. And thank you, everyone who attended this meeting.
And we'll send the link out for the survey evaluation.
Exactly.
Everyone.
And we would like to invite you. It's a good segue. Dr. Arismendes mentioned about telemedicine. We have a presenter next month on December 14, 2021, Dr. Shantanu Nandi, who is a famous author and CEO of Accolade Health. We'll talk about care after COVID, what the pandemic revealed is broken in our healthcare and how to reinvent it. Again, thank you very much, everyone. Thank you, Max. Thank you, Laura. Thank you, Dr. George. Happy Thanksgiving to everyone, and let's be kind to one another.
Thank you.
Thank you so
Thank
much.
you.
Thank you. Have a great one.
Yeah. Bye-bye.
Bye-bye.